An estimated 1.1 million Kenyans fall into poverty each year. And that's because of healthcare costs. Would SHA, SHIF, UHC change that, or is there more? Or perhaps, what's the difference between a pharmacy with a Blue Cross and a Green Cross? What about cancer and the rising incidence amongst the youth? Is it just lifestyle changes, or is there more? Women's health, men's health, your children's health, the economy, this and more awaits you on Season 2 of Kenya's favorite health podcast. My name is Dr. Diana Wangari, and welcome to Season 2 of the One Health Lens podcast.
But at the end of the day, and she said something really important. I won't blame you. You were not a decision maker then. When we fought to maintain regulation of training within regulators, our mother ministry did not defend us. I will tell you, it was at the stroke of a pen inside politics that took our regulators, the Nursing Council, the KMPDC, the lab, the farm, from regulating training institutions. When we reached out to our mother ministry to say, do not support, because it was a parliamentary bill. It was literally an omnibus bill, and things passed, and we fought it. And you know, it wasn't, what annoys me and pains me even was that it was an omnibus bill at CUE level, okay, that affected all regulated professionals. So engineers, lawyers, everyone. But guess what? It's only the health people that are listening. COE will still inspect your law school, and if you insist, you will graduate those people and they will not register them. So what's wrong with us? We're dealing with life, and our mother ministry is just being very complacent because all these regulators, and it's not your docket, you're a health financier, I'm talking about the quality people, are a problem. We didn't have an M&E department. What is it M&Eing over? What are you measuring when you haven't set the standard of what quality should? And quality is not an institution. It is the processes that take place in that institution. You understand? Those we are not measuring. That is, you know, when we say, is every baby who came with a fever in this unit taken through the same scorecard, checklist, whatever, before you determine how you treat. So what does that do? It becomes very prescriptive for how care will be delivered, but it's what the rest of the world has done. And what it has done is that you know that at least 75% of your issues will be addressed. And the 25 who are not fitting into your checklist now make a case for why you need to deviate from standard of care. So we are not, we don't have that in Kenya. So they are giving them a job of doing M&E over things they have no control over setting the baseline. And it translates, because I'm sure if that was done right, as economists, you'd look at the costing very differently. Because you'd be like, what are you talking about? If you have a broken hip, if you're below the age of 80, I expect this to be done. If you're above, it's not left at the discretion of the individual practitioner to decide, because the moment we do that, then fraud checks in. And when NHIF was here dealing with lost billions of shillings because payouts to hospitals. So I sit and I ask myself, I am an obstetrician, I deliver babies. Show me this hospital that raked up millions in a surgery that NHIF will not pay you more than 200,000 shillings for in this number. Where were they even these patients sleeping on top of each other? Because your bed capacity is, we know how to calculate how bed capacity, goes into turnover, into, you, even if you tell me you have 100 bed capacity and you're a maternity hospital, I'll tell you, there's no day you're delivering a number beyond a certain in a year, even if you have 100% bed occupancy. So those things need to be tied together. I think what we're keeping on saying is that this has started. We're here. We're going to have to work with SHIF very closely. The economists have to come in and make sure the costings are making sense. But as you're doing that, bring us in. The service, not service provider from a perspective, I'm paying you to give a service, but service provider from the aspect of we must assure a certain quality of care. And that's why I'm saying, let the people who give that care determine what is minimum. And because we are the ones who tell you when technology has changed, that, hey, now we have a cheaper way of doing it. Let me give you a common example. Even with the private insurance, a mother with a miscarriage, right now, if I was to take them for a procedure in a middle-level hospital, it's not going to cost less than 100,000 bob to do an evacuation. But the same insurance, when I ask them to pay me 20,000 so that I do it medically, they're not having that conversation. Why? No. So we tell them, okay, it's fine. Let me sign the forms for what you know how to pay for. And one time I remember talking to the nurse who was making that decision, and I explained to her, why would you want to cost more? And she told me, because I don't even know what that thing you're talking about is. So now we have told Chief that you must have professionals in the decision-making bodies. But when you tell them that they're going to put a clinical officer there to tell a cardiologist that intervention you're talking about will not pay. Are you getting what I mean? So show me, and that's why I said, you can't hack this without the professional associations. You don't need a cardiologist to sit there. But you can have an advisory committee for that particular thing that the MOH has to do. That says, every other time, this team will convene. Is it monthly? Is it quarterly? Can we review what it is we are seeing hospitals having to pre-qualify? Is it making sense? Okay, so all those checks and balances. That's why I keep saying, I don't care for the vehicle. The vehicle is here. We have built the house. We have painted. Basic furniture is in. You know how they usually say, if you want to know the house is working, is you can cook a meal and eat, and you will sit even if you sit on a bench, but you ate. We're there now. Now we're moving forward, and we're saying, now, are we deciding on the color of the carpet, what size of TV, and what have you? Please, let us get the necessary people in the room. We are here. We are happy to advise. I'm not alone. I will not bring all the expertise. I know many people. We now have the Society for Quality. It is here. We have the professional association. Pediatricians have done it so well for so long. RH, we have all these guidelines. We look at the Ministry of Health guideline for management of post-abortion care. Then you go to the package, and post-abortion care is not costed. So your mother who has miscarried, the hospital will not be paid for an evacuation. We're like, when you tell me that you involved my society, and my society cannot, even in KMPDC book, it is listed, what did you involve? So you get my point. It's a lot. It is heavy.
Yes.
We don't want to fight with our ministry. We don't want to fight with Chief. We don't want to disregard the support that Dr. Matiko and team are bringing. But tuingie tu sisi wote kwa stadium. All of us, because these players are very new. You understand?
Yeah.
And we look each other in the eye and say, guys, this is not a hotel room. We are not here for per diems. We're here to sit and decide, how do we make this work? Because it is in everybody's best interest for this thing to work.
I hear you. I mean, so we are going to have a part 2 of this conversation, and it was important to have Nelly here.
I actually just wanted to do a 1 minute rejoinder to this.
Yeah.
So, and I think we should treat the health financing piece in any, because this is a whole system. That's why at every point we have to step back and think of it as a health system. So health financing is just one piece, but I see it more as an enabler of a couple of things. But I think it's just how we who are working with the system, also around the governance structures of MOH, trying to see how does it enable the many things to happen. Because, one of the key observations that Nelly has made is over 11 years, maternal mortality. It's just one clear indicator. So you can imagine if we measured others. So if we went to blood pressure, we measured neonatal, we measured road traffic accidents and a couple of others, it could actually be on. But we just use one indicator and say, can we actually influence this simple one as one of the key deliverables? But what are the drivers to this? So if you look at, let's say we removed financial barrier to access, but we didn't assure that commodities will be at those facilities. We didn't ensure the health workers will be there because they were not paid in most cases. For a longer period of time. So those are the other aspects. While we even there to have clear digital system to capture all the data to give us. That's why MOH now, I guess they're saying they don't trust the information that is there. But again,
but they also don't have theirs to challenge.
We're talking about mothers are still dying. Even if between whether we say 500 or 200, there's still others that died. So those are other things that we need to come to. But so just my conclusion is, especially on that whole piece, trying to tie one of the key patient voices that said is, right now it's about how do we make the new house fit for purpose to enable the other pieces to come down, to fall into place. It's good we are going to, so are we going to incentivize by, because pay for results actually exists, so are we going to say for people who do this quality then there'll be an app? Are we going, so there are a couple of things that we can get into that can actually incentivize some of these things to happen, but I fully agree there are a couple of pieces that the new house needs to get in order for us to respond to the challenges that the other house didn't respond to, especially in trying to improve the very basic of things in health financing and any other system is to save lives.
Absolutely.
So let's prevent death at the very minimum. So that's, are we fitting for purpose? Probably that's what we should look into. Yeah.
Absolutely.
Yeah.
I think this is going to be part of the conversation. Okay. It will be. It will be. I mean, Nelly, thank you for coming and providing that input, because I think we'll sit here and we'll continue having part two of this conversation. But if we didn't have that to ground us and to remind us what this is all about, I mean, financing is a component, as you said, right? But also what's I think is coming out clearly is that there are pieces that don't speak to each other, right? It doesn't. And in as much as we all claim that we want a voice to the people, it's how we as, I suppose, professionals have the duty to represent the people. So if the pieces are not speaking to each other, when are you ever going to get Diana Bosire, who lives in XYZ, to come to have this conversation? It's representation, right?
That's true.
Comes back to the issues of governance and whatnot, right? But Nelly, thank you so much. We're going to continue the conversation shortly. We will hold the people in the room to task as we continue.
Please do.
We will, yeah. Given we have economists, we're talking about more financing conversation, right? And a big part has been that, one, we seem to have figured out how we're definitely going to get contributions from the employed, right? Yet there are questions around the informal workers. There's no even clarity, or at least it appears there's no clarity, right? I'll start with you, Wangia. What was the thinking, right, as we were rolling, at the Social Health Authority, SHIF in particular? What was the thinking in terms of just capturing different contributions?
Yes. So we know that in Kenya, close to 20% of the population are usually fall within the formal sector, while 80%, which is the largest chunk, fall within the informal sector. So the formal sector are, I would say, for lack of a better word, easy to capture because they have a salary, and historically, NHIF has been a statutory deduction. That means so long as you are on a pay slip or a payroll, you will definitely get the contributions. So the tricky part is usually how do you get hold? One, how do you get hold of the in the informal sector? And two, how do you retain them? Because you can have an exercise, get hold of all of them, but then how do you ensure that year in, year out, they are still retained? If you look at the Act, it had tried to address that issue, because we had said that in one or another, we will be able to get the informal sector, because most of this informal sector are in, will seek one service or the other. They are in business, they'll need to renew their licenses, they are borders, they are in circles, they'll need to, register within their circles. And just like the birth certificate, the way the issue of the birth certificate was incorporated within schools, and it was clear that for you to get into school, you need to show that you have a birth certificate, and that actually ensured close to 100% compliance to birth certificates, at least by entry-level school. Of course, we would want them to be earlier. And therefore, that is what the Act had envisioned, that will use some of these approaches to bring in the informal sector. The other aspect in which we can bring in the informal sector is when someone is convinced that this service actually works. Now, that is work in progress, a lot of work in progress, because sometimes if your neighbor tells you that they actually went, sought services, and they were okay, everything was catered for, or whatever, the scope was catered for, then they may be convinced to enroll. The challenge that we're having mainly is that most of the people in the informal sector who are coming on board are actually people in need. Someone has been diagnosed with cancer, someone has been diagnosed with renal failure, then they are just told, okay, go and register for NHIF /SHA now, and everything will be catered for. But what we need to invest more is the fact that we need to the whole concept of insurance should be broken down in simple language to the population, so that they understand that when they are sick, the money that is being paid for their illness is being paid for by contributors who are healthy. And therefore also them, when they are healthy, they need to keep contributing. I don't think it's a principle that very many people understand. We need to think of what is the easiest and simple way of communicating this message, and therefore people will feel within themselves obliged. And of course, the whole aspect of public trust. If you see where your money is working, and I can assure you, when we were doing this act, there was a whole afternoon debate on what to do with the excess money from SHA. And
there was excess money.
Before, if you look at NHIF, it has already, there is already an NHIF building. That means they had resources to invest in the building, buy land for whoever, the land in, is it? Karen and all that. So, for us, we stood our ground, and I know, and with a number of people, and said that there should be no excess money. Any excess money should be front-loaded to the next year and have the benefits expanded, so that you cannot say that you are making profits or making excess. Yes, even I'm sure, despite the large admin fees, there was still some excess. That excess should be used to expand the package the following year. If you have whatever billions, you say, okay, we managed to pay off this, we saved this, can we do projections and expand the package? So basically, what I'm trying to say is that getting the informal sector is very difficult. It needs a lot of, public confidence and public trust, which is something that, you cannot sell or buy. You just need over time to show that you are working.
Dr. Wangia. Let me ask Dr. Matiko. The question around capturing contributions from informal workers has been tried across the world, right? You have experience, you have interacted with other models of care across the world, right? What would you say, beyond the theory, right? What would you say has worked in other regions, and why has it worked? We're not saying it will work for us, but what seems to
Okay, good. So just to build up from what my colleague Liz has mentioned. So there are two levels of informal sector. There is the non-poor. So basically, essentially what she has described, the border owner and a couple of others. Those ones you can't really say they are the indigents. So there is that group, what I can now say, the non-poor one. But there is actually the indigent one. So there are those two levels that we need to remain quite cognizant about. That there are mechanisms we can build for the non-poor, but there are interesting other mechanisms we can build for the very indigents that we need to talk about. So as we talk about it, we must be looking at this too quite keenly. And so there are certain principles around this. So one is we have to choose there are two approaches that have been used across other countries. One is a direct subsidy for the indigents, for the very poor that we are talking about. So direct subsidy that needs an allocation from government. Okay, so that needs an allocation for this group. So, and that has been tried out in Rwanda, right? There is a budgetary allocation, and some of the budgetary allocation, by the way, you don't have to get it from the budget. So they have come up with innovative ways of actually raising that money to do this. So look, we have you're overspeeding, that money goes to the Rwanda Social Security Board to do this. You are registering a company. Part of that money goes to this. So it's actually part of those fees that we charge all over the place that can be tapped to actually go cover this population, which you're saying they have no other mechanism of paying for that. Direct subsidies from government. And so the next level is, what about cross subsidies? So cross subsidy from the private insurers. Can we get, they have tried, so they were doing 5% from the private scheme to do for the, for the broader pool, and now they're doing 10%. So basically you take 10% of the private scheme and take it to the other side to subsidize this other end, because the whole principle is you want to make sure that as you're pushing the non-poor informal sector, you're also creating incentives of the very poor, because we need to think this is about social solidarity. I need to look at it that I'm putting in this, but actually there's someone else who's very sort of off. But how do you identify? So they have done tremendous work, but again, some of these things are built from history, they're built from broader governance issues, especially, and I think all of us agree in terms of what happens on the other side, in terms of just the leadership and governance and the ownership that the communities do have around their health. So one of the elements that they did was to come up with their own mechanism of identifying the poor, especially community-led, community-owned mechanism of identifying the poor. Pretty, can say low cost, because the proxy means testing. Fantastic, scientific, but again, the practicality of it and the biases that come alongside it can present quite a challenge. And so this is likely to be quite a big challenge, but I hope it works. But for them, they actually came up with like, okay, on our community, we're coming up with stratification of 4 groups. So 4 groups, so the number 1, let that be the upper earning groups. Then we come with the second, which comes just close. Then the 4th group, let's just say they're paying 0, but we'll pay for them using the other mechanisms that I've used. So how do we do that? And the enablers I've said is clear community ownership and that sort of conversation that we've had. But again, there are governance issues in terms of building trust, because the other bit that they do have quite much, and I think Liz has talked about it, how do they build that trust for people to actually say, if I put in money, I'll actually get this service in terms of what I'm entitled to. Yeah.
Absolutely. Yeah. And it's quite clear it's not an easy job that you have, Dr. Wangia. It's not. It's not. And it's very easy for naysayers to naysayers.
I won't mention names.
We won't mention names, right? It's not easy. But we have to start from somewhere, right? And I think a big part is this conversation around trust, right? It's around even transparency, right? A direct question would be, what's being done for the common mwananchi to understand this is why you need to declare this information? Why I ask this question is you've seen reports, you've seen people who are saying, you must not say you live in a house, things like that, yeah. And ridiculous as it might be, it's because then they have been told that if you showcase this, then means you contribute more, or whatever it is, right? Is there work that's ongoing that people are not aware of? Because part of it is, obviously a lot of work is ongoing that people will know every day. This is what's happening at the Ministry of Health. This is what's happening with the Social Health Authority, the different elements that are trying to realize this vision, right? Is there work that's being done to educate people? Is there work that's being done to even just build this trust? It could be, yes, with common mwananchi, it could be with professional associations and others. Is there work being done?
Yeah, so when it comes to the means testing, of course, it's all a matter of self-declaration.
Yes.
The other alternative, which, of course, now with our current data protection, act, would be around, getting additional information from other sources. But then now that approach has not been used. What has been used largely is around self-declaration. Now there are 2 sides of the coin. There are people who have been told they're meant to pay, say, 20,000 a month, which comes to 200 and something a year. For those, there's what we call a 2-step method. So where you have a contestation method, contestation clause, where if you feel that whatever amount you have been given is too much, then you give consent for us to get information from whichever other source. And that's when you actually give the consent. And with that, we can maybe use, go to eCitizen, use other, secondary level data, but you'll have given that, you'd have given the consent. You'll have given the consent. This is mainly for those who feel that the amount they have been told. I don't think we'll get contestation of a low amount, though there's someone who told me that his grandmother was told to pay, his mother was told to pay 50 bob a month, and they were like, how is that possible? So that is again another contestation, but that one won't fall into the two-step. I think as a society, we need to get to that point where we are just genuine and we are honest people. And this has been seen in other countries, and not necessarily for the means testing. If you go to a country like Japan, where I've just come from this morning, if I leave my tablet here and it has any form of my information, it will get to me. That is a whole change in the culture of the people. So even as a people, we may not be able to say, okay, we'll come and verify as to whether you are, the information you gave is correct. But I think as a people, once we have that trust is built, we need just to be ready to give this information willingly. For the poor, still the same process. Actually, the means testing is not for identification of the poor. It's for identification of what are the premiums for the informal sector. Once your premium is less than 300, the next step is working closely with the counties and of course the chiefs. Now we have the county health and also say the local administration to verify, because the people in the local administration know who is poor. For sure, if you ask a chief who is poor in your location, they will tell you. They'll know the widows, the widowers, and all that. And I mean, they will be able to know that these persons are poor. So that is the step we're taking to implement that. Now, the other different thing, which has not been spoken a lot, is that this time, the Ministry of Health is not the one responsible for the indigents, payment of the indigents. Because remember, the issues of indigents are not only health. I may have a health issue, but I don't have food. Just dealing with the health, saying that I'm covering your health insurance, but I'm not having other safety nets, then it beats the purpose. And therefore, if you look at the Act, it's clear that the ministry responsible for payment of the premiums of the indigents, once all this process has happened, is the State Department for Social Protection. So that they're able to say, these are the people we know who are poor, these are the people who are receiving other forms of social protection, and therefore these are the people we are also going to bring in. So they're paying for maybe the education, food subsidies, and together with health. So those three go hand in hand. Yeah.
Hey, there are questions. There are multiple questions.
Yeah.
I mean, and we could go on and on, because I'm going to try stick to the financing element of it. And let me go back to Dr. Matiko, right? Because I'm starting to feel like we almost need a part 3, not today, but another time. Okay, ideally, what is meant to happen, right? Because we said we are trying to shift. The shift is because we want a more sustainable approach to financing healthcare services in our country, right? Or no?
Yeah, of course. It is. It has to be sustainable.
It has to be sustainable,
Yeah.
right? But we have questions around, the contributions, the issues around how we are capturing all that. Yeah. There's the questions around what people are thinking should be the allocation from government versus what's practical, right? There's the question around even our reliance on donors, right? Yeah. Because they do support many programs in this country, right? And it might not be a fair question for me to ask you.
Okay. Yeah.
It might not be a fair question, right?
Yeah.
But you've worked with Dr. Wangia, you've worked with people in the Ministry of Health, right?
Yeah.
What would you say will have been a practical approach to all this, right? Because we'll go on and on in circles, right? What should have been the first step? Should it have been, in financing, just financing, will it have been we identify how to capture, right? Will it have been we first start with an allocation? Where should we have started? Maybe there's no where, but what will have been the ideal scenario?
Yeah, so I mean, there's usually a very clear framework around how, health financing framework. So the first is raise, allocate, then spend. So the primary goal is just to put in strategy of raising that money. We have a clear indication of how much we need based on our projections, which I guess, I think the Ministry of Health and everyone else involved have a clear indication of how much they need. Then we go into how do we raise this money? Which mechanisms are we going to do that? Through taxes? Are we going to do that contributions? And how do we even do the contributions? We're going to do voluntary or mandatory. And of course, voluntary has its own challenges because I'll only contribute when I need. And that, of course, introduces the whole bit around adverse selection. And that might not make it sustainable. So there's a whole bit around let's first raise the money. So that I don't think, that is the fundamental understanding. And I think we should. And I think I'll guess that's the same thinking that the ministry has, and that's why there was a lot of hullabaloo around. Or let's get this from the formal sector. So that whole goes well. The second part is then once you've raised, because raising is just one of the pieces. How do you allocate the different health needs? And I know, Kigondu will say, but why did you leave this? Why did you get one eye of glaucoma and leave the other?
Exactly.
So there are all these things around where priorities are, and that goes to spend. So the spending side is where it now becomes even more interesting because it means nothing for you to raise all that money that does not result in direct service delivery. And all the conversation we had earlier around quality of care should be able to be moving all those levers around this. So spending, that's where the rubber hits the road around the mechanics. How do you incentivize quality? How do you do all this? But there are a couple, again, there at the spending side, 3 key questions come up. So from whom are you getting that service from? And that's the whole divide of public-private come in. And so, but this should be informed largely by quality of care. Let patients vote by their feet. So I go to where the quality is. And that is the fundamental principle, that the quality is here. So that actually incentivizes me, who wants more votes, people to walk in to raise quality. Have we structured ourselves to purchase from that perspective? Is a whole other conversation we can have. That's question 1. Question 2 is how do I do that? So how do I buy has principles around, are you going to pay fee for service? Of course, that has implications in terms of escalating costs. Are you going to do capitation and others? And of course, it has differences across different levels. And lastly, it's what are you buying? So what are you buying is around the benefits package, and I think we talked about it quite extensively in the earlier part. So it's just those fundamentals that we need to think about through the process. So to answer the last part of your question on, so what does this all mean to the now what has become a chorus around donor transition? I think quite a lot of that is happening. Is how do we make sure that all these funds that we have set right from the raising are sustainable and cognizant of the fact that almost a quarter of health budget currently is supported from the donor side of things. So if we acknowledge that, then that means at least as I think about a schedule to transition out, we have a clear plan around how we are going to fill the gap. Have we started thinking about that? I think there's a whole technical working group that is working on that, and maybe Dr. Wangia has that kind of perspective. But then again, we have also to acknowledge the weaknesses of the current donor landscape, and it's all about priorities. Because what happens is, if I'm giving you money, it's my priority you're going to deal with. And so how do we now own the priorities? And actually, maybe we might discover it's not as much that we need in terms of all this gap, because the priorities have been shifted to another direction that is of interest to certain areas, that it will be interesting for us to own the process, own the priorities, and drive that sustainably based on the fact that we raised well, sustainably, then we allocated well, efficiently, then we spent efficiently.
Kigondu.
Yeah, so as a parting shot,
Yes, please.
when you're dealing with economists who just look at numbers and they're not on the ground, then this is how they talk. Yeah, but all in all, I think we've talked a lot about these issues, and they're very right that the healthcare financing component is just one of the building blocks. And maybe we should be talking more and more about the whole ecosystem, which is the digital superhighway. And of course, we have beef with how they are taking our money and not offering service. I mean, it's pretty straightforward. As a gynecologist, when you're not doing what is called manual vacuum aspiration, they have deliberately removed it from the benefits package. Meaning, if someone comes with an incomplete miscarriage and will require manual vacuum aspiration, you have to do a harambe for it. Yet the amount of money they have taken from us is a lot. Secondly, it is evident, even from what you have heard the economy saying, is that the salaried worker will carry the cost of this. They will not be able to get the other informal sector. And we had an earlier discussion about this. And for a long time, Kenya Medical Association has always advocated for what is called a tax-funded, public-led universal health coverage. What does that mean? You raise the VAT to 18%, as Matiko has alluded to. Then 2% of it, 3% of it goes to financing the healthcare. And that way, you have gotten everyone into the net. This one, you have gotten the 20% to pay for the 100%. And I can tell you, people have learned how to beat the means testing, and they are being encouraged by their governors. So you are having the county government actually politically shooting themselves in the foot, meaning that they are the same ones who will have to pay that 300 for all those, but they are the same ones helping the people to beat the system and allowing the salaried workers to carry that. So at the end of the day, let's look at the bigger picture, the digital superhighway. I think Murang'a County.
Okay, fair. Dr. Wangia, I'm going to give you the final word. I'll give it the final word. And I can already tell when this episode airs, some of the comments that are going to come in is, why wasn't I more direct with you, more... I should have asked the hard questions, you know? And I should have, but I'll ask them next time, because one, I appreciate that you made time to come here today. We've asked multiple government officials to come. Most have said no. So first, I do appreciate that, right? And that's why I took time to just even listen, right? That's why the questions will come later. I'll even put out a poll so that people give those questions and I'll ask. So in case anyone wants to throw rocks, please do, but no, this is the reason. So Dr. Wangia, yes. I'll give you the final word. Moving forward, right? What would you want to tell Kenyans? And that's a general and too vague a question, but what would you want to tell Kenyans?
So, allow me to twist that question a bit and just say maybe what is it that we would have done better? Something to do with that. So number one, which will still answer that question in part, when it comes to communication, I think just like many technical people, we never think of the person as we start communicating. Because I would tell you, like, for us, me as government, we have the best interest at heart. But sometimes how we portray this messaging out can make or break. So I think it should be, and you know, in med school, we didn't do those common courses. I still think that it's very important for technical people to learn how to communicate. Risk, especially communication and even risk communication. When you see the spirit on the ground, how do you, you know, I don't want to say counter that, because we need to have already thought of these things in advance instead of starting to chase the lies. Because what we are doing is we are chasing the lies. Lies have already gone way ahead of us. Now we are chasing them with some truth. So for us, I think the communication. The other thing is county involvement. A lot of what we do, we did a lot, even at national level, in terms of, laying the ground and all that. But in terms of thinking through how to implement, we needed the counties, a lot of the counties, right from the beginning. And even when I talk of the counties, I'm not even saying the Council of Governors only, even the administration. We have the, what are they called? The
MCAs?
No, the administration, NGAOs, the National Government Administration Officers, like the chiefs, because we need this information to go down and be spread in the barazas.
Yes.
Do you know, in the villages and in the counties, people actually listen to things that are said in the barazas. So we need to have brought them together. And the other thing that I would maybe really consider is really working closely with also the professional bodies. I know we really need to come up with a common ground, because you see, and I always say, I've been in both areas. I've been a clinician and I'm now in policy. And at times, I know how clinicians think. You always think about your patient. But then sometimes there are many other considerations to be put in place for this patient. So sometimes I think we need to engage more. We need to engage constantly. I know through the partnership framework, we have all the way in which we will engage with the partners, but we don't have a clear structured way of engaging with the professional associations. So if you ask me, these are, if I become CS,
Usishout.
Please, we're on air. We're on air.
2032.
No.
2052.
No, I hear you. You know what?
Yes, those are things that I would think would really, they may seem, and first of all, they are low cost. It doesn't cost much just to communicate. Like the girls, by the way, you just sent a letter to the PS.
Yes.
Interior, and this information the following day will be spoken by all the chiefs. Yes.
I hear you.
Yeah.
Matiko. No, I mean, clearly communication is a big part.
Yeah.
Communication was a big part. And I'd say, I mean, brilliant minds were behind most of this, right? The heart is in the right place.
Yes.
Despite everything. I hear you. I mean, this is a conversation that we could take one topic and go each by line. But I thank you for coming, for making the time to stay from part 1 to part 2, for listening to the patient advocate who said she just wanted the platform while you were here. Thank you so much. Yeah.
Anytime.
Yeah. And hopefully next time when we invite you, do come again.
We'll create this duo. We'll come.
Please.
We have
Both
done this together by their number of
please.
times.
We've done this
Finishing us together. They have been finishing us together.
No. I think one of the things that Kigondu has, it comes in quite hard, but we'll manage him.
No.
Sometimes he throws shade, but we'll manage him.
We'll have to. We need to bring in more professionals. We'll see you next time on the One Health Lines podcast.
Okay.